Thank you. So Adrian mentioned this new technique of ultrasound lymphosonography for sentinel lymph node detection, and I'm going to go a little bit more in details and show you our journey through this technique. Have a few disclosures for you. So what is lymphosonography? Lymphosonography is contrast-enhanced ultrasound guided lymphatic mapping. We inject contrast agents under the skin, and then we map lymphatic channels. This is a very interesting technique because it's real-time imaging of lymphatic channels, and there is nothing pretty much in our toolbox that can match this resolution and temporal spatial resolution of this technology. Honestly, this whole idea of sentinel lymph nodes is changing rapidly. When I was in medical school and then beginning of my career, before we started looking at sentinel lymph nodes a little bit more closely, life was very good because the classic teaching is that tumors are extremely smart and organized creatures. They drain, the lymphatic channels will drain into one single sentinel lymph node. And if you find this lymph node, if you biopsy it and you see tumor in there, then you can go from there and find the second stage sentinel lymph node, and you can stage your patients accordingly. Clinical gold standard right now is sentinel lymph node biopsy using radioactive dye injection. You can inject them in a tumor or around the nipple. In a quadrants, then you use radioactivity probe to find those sentinel lymph nodes. You take them out and you diagnose your sentinel lymph node involvement. Unfortunately, lymphosonography has lots of limitations, as you all probably know by now. One of the most important one is this non-sequential enhancement, when the staining or radioactivity uptake occurs in the second echelon lymph nodes, bypassing the first lymph node. We don't really know exactly why it happens, probably because first lymph node is either necrotic or most likely because lymphatic channels leading to these sentinel lymph nodes are completely blocked by tumor. There is this shine through that we can miss lymph nodes that are very close to the injection site, and we see this quite often in our patient. And then also difficulty pinpointing very tiny sub-centimeter lymph nodes because lymphosonography resolution is extremely poor. But when we start looking at those well-organized channels that we supposed to see in patients with breast cancer, it's actually not true. Those tumors, they don't follow guidelines, they don't read books. They're like angry teenagers, they do whatever they want, and we see tumors draining into multiple chains, producing multiple sentinel lymph nodes. We had a couple patients with tumors in the outer quadrants of the breast, draining lymph nodes into axilla in subclavian lymph nodes, but also sending very long channels across the chest in the contralateral subclavian area and sometimes into internal mammary chain lymph nodes. So this idea of single sentinel lymph node per tumor is actually kind of probably under attack, and I don't think it's true because tumors, especially large ones, will drain into multiple basins, and finding those sentinel lymph nodes with lymphosonography with injection of the radioactive dye is extremely problematic. So with lymphosonography, you basically replace radioactive dye injection with injection of ultrasound contrast agent. Instead of radioactivity probe, you use the ultrasound probe, and you can trace those lymphatic channels. You can find sentinel lymph nodes, and you can take them out. This picture is here with the tumor injection is there for a very important purpose because we spend very long time trying to inject ultrasound contrast agents and trying to inject radioactive dyes in the tumor or around the tumor. Because our first idea was, hey, if we are mapping lymphatic channels of the tumor, let's inject around it. and see if we can map it from there. But unfortunately, it failed miserably, and we stopped doing it. The main reason why lymphatic channels are so difficult to visualize around the tumor is because they're all blocked by tumor cells. If you have large tumor, if you let it grow, there is desmoplastic reaction, there is inflammation, there is an infiltrative growth of tumor. All the lymphatic channels right next to the tumors, they will be blocked. And if you inject your radioactive dye, you inject your microbubbles, you're going to see absolutely nothing. So now we inject in a quadrants, we inject in 4 quadrants around the nipple. We usually inject probably 0.1 to 0.2 ml, and we use Sonozoid for those injections. If you don't have Sonozoid available, Sonoview works just fine, but Sonozoid bubbles are a little bit stronger than Lumason or Sonoview. They last longer, and we actually seen a couple patients who would get lymphosonography the day before their surgery, and when we go and do surgical excision, we will still find some bubbles sitting on those lymph nodes. So Sonozoid bubbles and probably Sonoview as well will stay in the lymph nodes for quite some time. After you inject your ultrasound contrast agents, we usually very gently massage skin around the nipple and the breast tissue for about 5 to 10 minutes, but very gently. We don't want to disturb microbubbles. We don't want to break them. And with a high-frequency linear transducers, you will be surprised to see those lymphatic channels appearing, radiating from the side of the injection, guiding you straight into sentinel lymph nodes. For the reasons not really known, those bubbles will stay in the first in the first lymph node they can find. They do not go to next step, next stage. So only one lymphatic channel will lead into one lymph node. And this is actually very, very interesting and very good because we don't want to see multiple lymph nodes because we want to tell our surgeon exactly where to go and what to take out. If this becomes positive, then you can inject area around it, hopefully with less effect of lymphatic channel block, and then you can kind of do it in steps and find the next stage of the lymphatic drainage. Those channels come in different shapes and forms, some of them very thin, some of them pretty massive, leading in a small, tiny lymph nodes that I would be really, really hard-pressed to find this on beam-mode ultrasound. And we can find lots of small, tiny lymph nodes that in the large breast and in the large axilla in a patient with very fatty tissues, with a small, tiny lymph nodes, it's a challenge. You know, you've been there. It's a massively abnormal lymph node with no fatty hilum and 2-centimeter lymph node with, round morphology. That's easy, but those 7, 8, 10 millimeter lymph nodes, especially when they have fatty hilum, is quite a challenge. Also, we've seen quite a few lymph nodes with fatty hilum that on pathology become pathological or metastatic because lots of those lymph nodes will have metastatic deposit along the cortex of the lymph node, and the hilum will actually be preserved. So again, another thing that is out of the window in my mind, I don't use fatty hilum as a sign of benign lymph node because we've seen a ton of metastatic lymph nodes with preserved fatty hilum, especially when they're small and at the early stages of metastatic involvement. So we did a small study. I can't compare our experience to Adrian's, but to perfect this technique, so to speak, we had 12 healthy volunteers, and we injected them with radioactive dye, with microbubbles, and then we injected them with blue dye, and we did all 3 those methods, and we look at them comparing to each other. And you can see in healthy volunteers, the number of lymph nodes per patient was much greater than 1. On average, we saw with one single dose of contrast, the average number of the sentinel lymph nodes was 1.8. And if you increase your dose a little bit, we can have more lymph nodes. So on average, every patient will have about 2 sentinel lymph nodes per zone. Again, 1 lymph node per quadrant goes out of the window. It is not very pleasant procedure, so to speak. Some patients would have redness. Some patients would develop a little bit of a pain and then some bruising. But those are minor and they're pretty much similar to injection of radioactive dye. Was no significant difference. We also had 10 cancer patients that we did this study, and this was done with dye injection, with radioactive material injection, and with microbubbles. And unfortunately, our results are not as fantastic as Adrian presented. Negative predictive value was only 60%. And the reason for that is we finding more lymph nodes with bubbles than lymphosonography, which has negative predictive value of only 20%. But we're still not finding as many lymph nodes as blue dye injection. So if you want to find every single lymph node in your patient, do blue dye, but then you're going to drive your surgeons crazy because you're going to find 5 lymph nodes and you're going to be asking them to take 5 lymph nodes out, and not all of them will be malignant. But again, this is much better than lymphosonography, but if you need absolutely best method, do blue dye. So after you find 3, 4, 5 lymph nodes per patient, what do you do? And initially we saw those pictures, and we are very happy to see them, that benign lymph nodes, reactive lymph nodes, fill completely with contrast. They will present as a nice enhancing globs. And we thought, okay, if you lose this, if you have cancer, replacing some of the lymph nodes, the lymphatic channels will be blocked, microbubbles will not go there, and then you're going to have normal part of the lymph node retaining bubbles, and then this large cancer deposit in the lymph node will be black hole. But unfortunately, we also saw a lot of lesions like this with patchy enhancement, and we didn't know what to tell about those. And they were split pretty much in 50-50. Metastatic lymph nodes with patchy tumor involvement, and also reactive lymph nodes with edema in a lymph node will also block some of the channels and prevent microbubbles from getting in. So lymphosonography is very good in detecting lymph nodes, but it's not very good in characterizing them. And our surgeons told us to go away because they don't want to take 5 lymph nodes out per patient. It's just, too much. So we said, okay, what can we do to characterize them? And we decided to try this new fancy thing of molecular ultrasound. As you know, microbubbles have these PEG spacers on the surface of them to prevent them from forming one big giant microbubble, and also to improve stability. And then using some chemistry, you can actually attach antibodies to the surface of the microbubble, coat microbubble in antibodies, inject them IV, and then wait for those microbubbles to launch on receptors expressed on the surface of endothelial cells. Quick example, this is the mice with a tumor implanted under the skin. You inject targeted microbubbles, and they will flow through the system initially like normal microbubbles. But if you watch closely, some of those microbubbles will stick. They will be retained by the tumor. And if you wait a few more minutes, all free microbubbles will be washed out, and you're going to end up with large amount of microbubbles stuck to the receptors retained by the tumors. And then if you zip them with a high intensity ultrasound beam, you can eliminate all these microbubbles that were attached to the receptors, and you can probably see a few of them floating in. What's good about it, you can use this to quantify molecular features and molecular composition of the tumors, of the lymph nodes, of whatever you have your vessels in. And you can, for example, if you use bubbles that are targeted to these VEGF-R2 receptors, high expression of the receptor in the tumor will correlate with very high amount of signal in the lesion that you will see on molecular ultrasound. So what we did, we split this crazy study in 2 parts. First, we did sentinel lymph node identification with subcutaneous injection of Sonazoid, and we would find sentinel lymph nodes. We would mark them, and after we know where they are, we would inject targeted microbubbles and see if we can characterize those lymph nodes using molecular ultrasound. We did this in swine. It's not ready for clinical translation yet because we don't have a clinically translatable microbubble commercially available yet. We had 25 sentinel lymph nodes and 18 non-sentinel lymph nodes that we examined. All of them were surgically removed and analyzed for amount of metastatic involvement. And actually with this technique, with molecular ultrasound, after you find your lymph nodes with lymphosonography, our results were pretty good. We used dual targeted microbubbles targeted to VEGF receptor and P-selectin, and you can see that those lymph nodes, metastatic lymph nodes that retain large amount of targeted microbubbles. Those were control microbubbles labeled with IgG, with a sham protein, just to make dual control, so to speak, internal control in this experiment. And you can see the exactly same lymph nodes retain absolutely no agent that was just labeled to IgG. Benign lymph nodes, thanks God, retained none of the dual targeted agents and retained none of the control microbubbles. So basically with injecting of this VEGF and P-selectin targeted microbubbles, you can really highlight metastatic lymph nodes, and your benign lymph nodes will have no contrast retention after a while. Was a very statistically significant difference, so I think this technique, when we have clinically available molecular ultrasounds, will be very, very helpful because it will combine our ability in finding lymph nodes with ultrasound and also characterizing them as well. Our results were also confirmed with this fancy histology and immunohistochemistry, when amount of retention of the microbubbles in the lymph node really nicely correlated with the degree of expression of the targeted proteins in the body. So as a conclusion, lymphosonography, I think, is very interesting and rapidly developing method of sentinel lymph node mapping. It's not perfect, but it's much better than current quote-unquote clinical standard of care of nuclear medicine lymph node mapping. Unlike other methods, it offers unique ability to directly visualize both lymphatic channels and lymph nodes, and you can guide surgeon to take them out when you see them. If they don't want to do it, or if you're finding too many lymph nodes, we can hopefully characterize them using intravenous injection of targeted microbubbles that will go and lunge on the receptors expressed predominantly in malignant lymph nodes and not expressed in benign or reactive lymph nodes. I want to acknowledge some funding that we got from NIH and some industry, and I want to thank you for your attention.
Thank you, Andrej, to respect the timing. And I am sure that you will have many questions. I promise you that the increasing level of the quality of the presentation is going on, and I hope that Richard will be the best one. Okay, have you any question or comments?